So thank you so much, Professor Adebola, for the introduction. So last week, which was the first session, we had opening remarks by the incident manager, Dr. Patrick Ramadan at WHO AFRO at the regional office here in Congo-Brazzaville. And he highlighted some key aspects within the response, and also highlighted some of the contributing factors, which have been climate change, cyclone, humanitarian conflicts. We also have droughts in the greater Horn of Africa. Then we have issues with food insecurity and fragility in communities. One of the other issues he highlighted was the need for prevention, which means that we need to have water, sanitation, and hygiene infrastructure to be top-notch so that we can prevent cholera from occurring. He also highlighted the need for hygiene and health promotion in communities, also to take care of food and also waste in the community, because these are the things that really make cholera to perpetrate and be transmitted. He called for colleagues to really increase their index of suspicion, and countries need capacity for confirmations. One of the key aspects within the response is risk communication and community engagement, which is very important to engage the communities. Also, the need for improvement in water, sanitation, and hygiene. He also called for surveillance to be more sensitive and prompt reporting. Case management, he noted that member states really need to improve on this because the case fatality rate is high and we should be below 1% of the WHO recommendation. Professor Bola took us through the aspects of the overview of the cholera outbreak in the African region, and she talked about that there was really no need for anybody having cholera to die, which is important, which talks about prompt detection, prompt treatment so that we can reduce this fatality. And he also talked about the response strategies. And this is hinged on two key issues, on limiting mortality and also reducing the spread of the disease. We had the next presentation, which was on surveillance. It was taken by Dr. Dr. Felix, I beg your pardon, and he dealt on the surveillance aspect, declaring the start and end of an outbreak. He highlighted issues of case definition, the suspected case, probable case, and confirmed case. This was followed by Dr. Fred, who took us on the laboratory testing strategy, which is very important as part of detection. We talked about the need for the use of rapid diagnostic test kits, which is essentially for screening. And confirmation is by culture and polymerase chain reaction. He also highlighted that sequencing does not change the response. He also spoke about issues on sample management, logistics, and environmental sanitation. So this was just the crux of what we had over last session, and which was very interesting. So today we'll be starting with the next topic, which is on cholera case management, essentials to know and to do during outbreaks. So this will be taken by Dr. Rashidatu Kamara. So Dr. Rashidatu, the floor is yours.
Thank you, Dr. Olaolu, and good day to everyone. I will be taking you through the essentials of cholera management, what to know and what to do, the essentials of what to know and what to do. So this is a brief overview of what cholera disease is and what the causative agent. I know you've heard a lot about this, but then just briefly, we know that cholera is caused by bacterium Vibrio cholerae, either the type 01 or type 0139, and it is an acute diarrheal disease. About 80% of people that are infected with cholera will be asymptomatic, but then 20% of those who are infected will develop acute watery diarrhea. And among these 20% that would develop acute watery diarrhea, another 20% would likely progress to profuse watery diarrhea, which could lead to severe dehydration and death if not adequately treated. When this situation arises, the case fatality, could be about 30 to 50%. But however, if prompt treatment is provided, the case fatality should remain below 1%. So in short, cholera disease is treatable and death is preventable. So just a brief overview again of the fundamentals of the clinical management. The aim is to reduce mortality and also morbidity. And it is crucial that patients are able to access treatment very fast, to be able to access oral rehydration salts through the establishment of oral rehydration points within the communities, to be able to be early rehydrated with ORS for both children and adults. And in doing so, structures and systems must be put in place so that children and adults will be able to access ORS easily. And then to be able to access the appropriate treatment plan. So now, when a patient is suspected of cholera, this is what should apply. But then let us consider the case definition, which healthcare workers should be able to know. And to support these case definitions can be hung on the walls so that it will be an easy access for them to be able to identify or to raise their clinical index of suspicion. So the first one is for suspected case, and this is highlighted in green on my right. In areas with no outbreak, then a suspected case is somebody who comes in with acute watery diarrhea, with severe dehydration, or a person who dies or below the age of 2 years. But then again, in areas where cholera outbreak is occurring or ongoing, then the suspected case definition is in someone with acute watery diarrhea or death from acute watery diarrhea regardless of age. And then, of course, for patients that are confirmed, that is in countries with cholera, then it should be PCR confirmed or culture confirmed of the Vibrio cholerae 0139 or 019 in a suspected case. So now when a patient comes in, the first thing as clinicians or healthcare workers that you need to know is whether this patient fits the case definition. If the patient does not fit the case definition, then you manage this patient in an outpatient department. However, if the patient fits the case definition, we would need to assess the degree of dehydration of that patient. So you quickly triage the patient. If there is no dehydration, you can send the patient home with ORS. You teach the patient how to use the ORS, how to mix the ORS, and how to drink the ORS. Or you can manage the patient in an ORP or in an observation area. If the patient do have some dehydration, then that patient could be admitted to an observation area within a CTU or a CTC, and then put on oral rehydration treatment. But then if the patient has severe dehydration, that patient must be promptly admitted and then started on IV fluids or oral rehydration, and maybe if the need requires antibiotics. So now when the patient is admitted, you need to include the patient in the line list, and then you need to register the patient Then this is mandatory. All patients should be weighed because treatment is based mainly on weight, or you could estimate the weight, that is if scales are not available. And then you need to calculate the fluids that the patient needs using the GTFCC tool. This is imperative to be downloaded for all healthcare workers managing cases in facilities, in treatment facilities. And then you'll need to understand how the GTFCC tool operates. So for each patient, what you would need are the personal information, and then you record the clinical signs and symptoms. And then upon your assessment, you need to document your findings, and then the protocol or the plan of treatment that the patient is put on. And then the laboratory data should also be included in the patient's record. And also when the patient is discharged, you would need to include that on the clinical record. On my right is an admission and triage form, which could be downloaded from the website as shown below. So now assessing the levels of dehydration, these are coded. The green means no dehydration. The patient could be managed, as I said earlier, at home or in an ORP. And in yellow, if the patient do have some dehydration, and then the red, it's an alarming or alert sign, then the patient should be managed in a CTC or CTU. So now the signs that you would note in a patient with no dehydration, please let's take note of these, are when the patient is alert, the patient is awake, there is normal pulse in that patient, the patient drinks well, and then the eyes are not sunken or the skin pinch is normal. In patients with some dehydration, however, you would see at least two of the following. The patient is listless, otherwise irritable. The patient has sunken eyes. Below you can see a patient with sunken eyes, and the pulse is very fast. Or the patient drinks very eagerly, and then the skin pinch goes back slowly. On my extreme right, you would see a patient with very slow skin pinch. For those that are severe, the patient normally presents as lethargic or unconscious. The pulse is weak or in fact absent, and then the patient shows sign of respiratory distress. Or again, the patient is unable to drink or drinks very poorly, and the skin pinch, when you pinch the skin, it goes back very, very slowly, and then you would see sunken eyes in that patient. So now, with regards to the degree of admission of the patient has severe dehydration, you would need to admit that patient to CT or CTC, and then you need to commence treatment plan C, which we'll discuss in the next slide. And then if the patient has some dehydration, again, this is just to reiterate, the patient needs to be admitted, and then you would commence plan B. And then if the patient has no dehydration, then the patient could be managing an ORP or at home using plan A. Unfortunately, this slide is not too clear, but then I'll take you through step by step. So we'll start from my right, in which it is plan A, as I'd already highlighted. The signs are the patient is alert, normal pulse, the patient drinks well, eyes are not sunken, the skin pinch is fine. So what you would need to do is to prepare ORS for that patient and observe over 4 hours. Kindly note at this point that when you're managing cholera patients should be monitored. And in this patient with no dehydration, you could observe this patient for over 4 hours. So now when you're giving patients that has no dehydration, it's age dependent, and also remember I spoke about the weight, you'd have to give ORS. So for children under 2 years, you would give between 50 to 100 mils of ORS. Patients 2 to 9 years, you would give between 100 to 200 mils of ORS. And patients that are above 10 years, kindly allow them to drink freely. let them drink as much as they want. And then you would consider discharge after observing that patient for 4 hours when the patient has no sign of dehydration, the patient takes ORS without vomiting, there is no watery stool for the 4 hours that the patient has been under observation, and the patient can walk without unaided, and the patient passes urine freely. I hope we're all together. Now for plan B, as seen in the middle in yellow, if the patient is irritable, there is some sort of slow skin pinch, there is rapid pulse, sunken eyes, then that patient should be given ORS, but then that patient should be in admission, and the patient could also be observed for 4 hours. And then again, if the patient is less than 4 months and weighs under 5 kg, you can give that patient ORS 200 to 400 mils. 4 to 11 months and weighs between 5 to 7.9, 400 to 600 mils of ORS should be given. 12 to 23 months and weighs 8 to 10.9, 600 to 800 mils should be given, and so on until over 15 years, and the patient is above 30 kgs, you would give about 2,200 to 4,000. Please note that these slides will be shared, and we encourage all to put these posters up so that you'll be able to use them accordingly. And then these patients you need to reassess frequently, as I said earlier, at least every hour. But then if the patient, after your assessment, is alert, the patient is able to drink, the patient's pulse has improved, and then you go back to your plan A. And in this, you'll also observe for another 4 hours. You look at the patient, and then if the patient, after this period of observation, has no signs of dehydration, it's fine from your assessment, this patient can be discharged. However, if this patient continues to show signs of severe dehydration or is persistently vomiting, then you need to activate your plan C. And the plan C is wherein you manage the patient for severe dehydration. And the common signs that could be seen are the patient is unconscious, the pulse is absent or really weak, the patient is in respiratory distress, or the patient cannot drink well, the skin pitch goes back slowly, or there's sunken eyes. So for this, instead of oral, you are going to give that patient IV fluids, and the fluid of choice is Ringer's lactate. So now for under 1 year of age, for a period of 6 hours, the first 60 minutes, you would need to give the patient 30 mils per kg of Ringer's lactate, and then followed by 5 hours of 70 mils per kg of Ringer's lactate. And then if the patient is above 1 year of age, for the next 3 hours or over 3 hours, the first 30 minutes, you would give 30 mils per kg of Ringer's lactate, and this would be followed by the next 2.5 hours, 70 mils per kg. Let us also impress on you that patient must be monitored to prevent complications. So you need to reassess this patient very frequently, between 15 to 30 minutes. And then if the rehydration status improves, the patient is awake, able to drink, then you would revert to plan B. However, we can also need to include antibiotics treatment for patients with severe dehydration. So we will discuss that in our next slide. So this is just to reiterate the treatment plan, as I've already said. And if the patient is well, then you will discharge the patient based on your assessment. Again, for plan B, if the patient, after giving the ORS, the patient is well, the patient is awake, able to drink, and has improved, then you can go to plan A again, and then upon your assessment after 4 hours, then you'll be able to discharge your patient if the patient has improved. However, if the patient deteriorates or is worsening, please go back to plan C and manage your patient. And then for plan C, this is what you would need to do, as we've already mentioned, manage your patient with IV Ringer's lactate. We're saying this over and over again because this is the essential of treatment, and you would need to know that adhering to this plan keeps the patient alive. Now for plan C, be encouraged to use more than one IV line, because the clinical features mostly would be that the patients do have collapsed veins. But then again, if the veins are so collapsed that you cannot identify and insert a line, then what you would need to do is to either use the femoral vein, or you can even use an NG tube if the patient is not vomiting. Again, it is important not only to go as accordingly to the treatment plan without thinking of the ongoing losses. You would need to add extra or additional fluids to the treatment plan so as to compensate for the ongoing losses from these patients. So patients with severe cholera typically requires about 200 to 350 mL per kg of isotonic oral, that is ORS or IV fluids. And then you should ensure that you estimate and replace ongoing losses even after correcting the initial fluid deficit as according to the treatment plans. And then in areas where the cholera cuts are used, it is easier for you to estimate the fluid losses. And ongoing losses can be estimated as 10 to 20 mL per kg for every stool or after every vomit. Ensure to add on these estimations to the fluids that are highlighted in the plans. Now, with regards to antibiotic treatment, they are recommended or indicated for cholera patients that are hospitalized with severe dehydration and in pregnant women, or patients that are passing a lot of stool, or there is obvious treatment failure, regardless of the dehydration, of a patient with coexisting conditions or comorbidities. And the antibiotic of choice, the first line is doxycycline, 300 milligram orally as a single dose. That is in adults. In children, under 12 years, you can give doxycycline 2 to 4 milligrams per kg, again as a single dose. Alternatives are azithromycin or ciprofloxacin. So the use of zinc is recommended in children as it reduces diarrhea, volume and duration of the diarrhea. If available, it should be commenced immediately. And children, however, children receiving therapeutic food, that is those that have severe malnutrition, would not require additional zinc because their supplements already contain zinc. So this is just in passing briefly on severe acute malnutrition in patients with cholera. It is advised that you use only this plan or this protocol if the children have either SAM, marasmus, or kwashiorkor. What you need to do is to measure the mid-upper arm circumference, and if it's under 11.5 for under 5s, then you need to start your treatment. All children with severe acute malnutrition with a suspected cholera must be admitted. Malnourished children should be given ORS and please not Resumal. And we encourage mothers to continue breastfeeding their children. And also in pregnancy, there is no greater risk of pregnant women being infected by Vibrio cholerae or developing symptoms than the general population. So we don't need to be scared of that. However, dehydration in pregnancy can lead to fetal complication, including fetal demise. And let us know that management is the same, especially in the first trimester. But then in the second and third trimester, ensure to put the woman in a supine position on her left side. You look at the blood pressure, monitor the blood pressure of the pregnant woman, and then only transfer the patient for obstetric emergencies. Otherwise, you manage in the CTU or CTC. So now briefly, the complications of cholera include electrolyte imbalance, hypoglycemia, diabetes, renal failure, fluid overload, and also, as we've already said, in children with severe acute malnutrition and pregnancy. So when you are giving fluid, you need to be thinking if you see any changes, neurological changes such as confusion, patients complaining headache or their seizures, you need to think, how am I loading this patient with fluid? If there are respiratory complications, if there are cardiovascular complications, you need to think. And if that is the case, you would either need to reduce your fluid or you would have to stop the fluid. I like this slide because it shows that your patient is now ready to go back to normal activities. And that is one of the clinical benefits and satisfaction for every clinician. So when you're looking at this, after the patient has been fully rehydrated and there is no lethargy, the patient drinks well normally, the urine output is fine, then we can smile. So now when you're discharging your patient, you need to look at this criteria that the patient has no sign of dehydration, is able to drink or to take ORS without vomiting, no watery stools for 4 hours, and is able to walk unaided. We would need to talk briefly about the cholera treatment facilities, and we've mentioned the oral rehydration point. Basically, what we need to know is that these ORPs should be decentralized as best as possible, and patients can easily access these ORPs. And then the selection sites could be areas with high incidence rate. There is a larger load of patients, and if there is high CFR or many deaths reported in the community, areas with poor access to health care, again, these are sites that you can put in your ORP. And then select a location so as to ensure the patients can easily access these ORPs. You can put your ORPs in a fixed structure, or even a mobile structure, or integrated into the health care structure in a health facility. For the treatment units, we have the CTCs, which are a bit larger, and the CTUs, which are smaller. CTUs normally have smaller capacity and are normally attached to existing health facilities, and the CTCs could be independent with larger capacities. But then, let me just go back to ORPs. For ORPs, you would not need to admit the patient. The patient could only be observed for a number of hours and then sent home. Whereas in CTCs, the patient should be admitted and closely monitored. I think this is my last slide. I thank you for listening, and we are with any questions. Thank you.
So thank you so much, Dr. Rashidat, for that eloquent presentation. And you can see that there were several questions that were asked on the Q&A in the Q&A chat box, and colleagues have received quite a number of responses from what is GTFCC and other issues about the presentation. So presentations were sent to colleagues' email. So please let's be patient till the end of this presentation so that we don't get distracted. I don't know whether we have hands raised to ask specific questions at this point in time. seems there is no hand raised. I guess one thing which I could ask during this session, quickly, Dr. Rashida, since there's a chart that what's the significance of 4 hours wait to observe. I think that was one question that came up. Some other questions that came up is about the 2 year age to really detect cholera. 2 years is just a surveillance indicator. Anybody can have cholera, and I think we should note that. So we have the hand raised. Okay, the hand is back down again. Okay, Dauda Simpara, I guess you can. Yes, kindly unmute your mic so that you ask this question for the.
Ok, merci bien, monsieur le modérateur. Bonjour à tout le monde. Merci également à docteur pour la présentation. En fait, je voulais juste savoir par rapport à la réhydratation chez les enfants malnutris, les enfants malnutris atteints de choléra. Quand on doit les réhydrater, quels sont les aspects à prendre en compte? À vous. Est-ce que j'ai été bien entendu?
Oui, on vous a entendu.
Ok, merci bien, merci.
Okay, so got that question. Let me allow Kate Albati to respond to, as one of the panelists. Kate, can kindly respond, can speak.
Oui, merci. Je vais répondre en français aussi. Ça va faciliter pour la personne qui a posé la question. Donc, merci beaucoup pour la question. Il y a un protocole particulier pour les enfants malnutris, car comme j'imagine, comme vous avez posé la question, il peut être beaucoup plus fragile par rapport à d'autres enfants qui n'ont pas une malnutrition aiguë. Sévère aiguë. Donc, il y a différents aspects qui étaient montrés dans la présentation de Dr. Rachidatou. Un, c'est que si le patient a une réhydratation orale, c'est l'exception à la règle et le patient est réhydraté avec du SRO normal, habituel, pas avec le rhizomale. Et ça, c'est la seule exception. C'est très important. Il y a des gens qui le savent, mais je vais juste répéter qu'en fait, l'histoire de SRO, c'était créé pour traiter le choléra. C'était l'objectif thérapeutique du développement du SRO. Et ça équilibre mieux les pertes dans les selles de choléra que d'autres solutions. Donc, ça, c'est la raison pour laquelle il y a plus de sel qui est perdu et peut-être pas assez de potassium, mais ça, c'est un premier point qui est très important. Mais je ne vais pas passer par le protocole, mais il y a un protocole, le site que j'ai montré j'ai indiqué dans le Q&A, il y a le site du GTFCC, donc www.gtfcc.org, ressources, et il y a un protocole pour des traitements spécifiquement des enfants malnutris, où le protocole de réhydratation est beaucoup plus long que pour d'autres enfants. J'espère que ça répond à votre question.
Thank you so much, Kate, for that response. Dr. Rashida, is there anything you want to add?
Thank you again, Kate and Dr. Olaolu. I think I've been going through the chats and the Q&A, and I think the questions have been responded to by Kate. Thanks, and over.
Okay, thank you so much. I think several of the questions have been responded to in the Q&A. And just to reiterate that the 2 years of age is just a surveillance indicator. Anybody can have cholera, and that has been responded to in the chat. So if there are any other questions relating to this, you can still put it in the chat. There will be a response to those questions. So we will at this time transit to the next presentation, which is on infection prevention and control in treatment facilities. So this presentation will be taken by Dr. Deborah Barasa. Dr. Deborah, the floor is yours.
Okay, good morning, good afternoon, colleagues. So I'll go ahead and share my screen. So I'll be presenting on behalf of the IPC team. Okay. I'll be presenting on behalf of the IPC team. With us today, we have Dr. Landry Kabego and also Mr. Ndai Makamure. And I believe they'll also be able to answer a few of the questions that colleagues will have. So I was tasked to look at infection prevention and control for the cholera response in AFRO region. So we'll be using the GTFCC assessment tool as well as WHO recommendations. So colleagues, you remember the first day of our meeting, Prof. Adebola had shared with us this slide and really showing the Fs of transmission of conditions such as cholera. So cholera transmission is through the fecal-oral route, and you can see on the extreme left the feces, which are normally contaminated with the microorganisms, and through fecal-oral, one can get infection, and this can be through contamination of fluids such as water. That's why we talk about chlorination of water or having safe water. Again, the fingers, contamination of the hand, as well as vectors such as flies and the fields. So here we're not just talking about the fields, but also the surfaces, the environmental surfaces within the healthcare facility, as well as within the community. So through this, then there's the direct transmission to the new host or via foods that are eaten, which are not safely washed or properly cooked to get rid of the microorganism. So clearly from this, we can already see how we can counter that by safe water, hand hygiene, vector control, cleaning and disinfection, and food handling, ensuring that we have safe handling of food. So basically, those are really the infection prevention and control measures that we take during cholera response. However, in the facility level, it is critical for us to note that we really need to look at the standard precautions as well as the transmission-based precautions. The standard precaution, as you can see in the center, that is highlighted in blue, it is the core of IPC. Standard precautions should be, are measures that are put or precautions that are put in any healthcare facility whenever there is whenever there's an outbreak or there is no outbreak. So these are usually the bare minimum precautions that need to be in place. So you will all agree with me that hand hygiene is really critical, critical precaution, whether there is or there's no cholera, because our hands are really, a reservoir or a carrier of microorganisms from one patient to another, from a facility to the community, among health workers, etc. Again, respiratory hygiene needs to be emphasized. Even though we are talking about cholera response, you know that within a facility setting, we can have respiratory conditions, and so we need to adhere to those measures. PPE based on risk, whatever measures, whatever risk we are dealing with, we need to wear the appropriate PPEs. Again, safe injection practices and sharps management. At times I hear questions, colleagues are asking, why safe injections? And Dr. Kamara has clearly talked about for severe dehydration, we need to fix a line, we need to start patients on IV fluids. And also there are certain maybe sharps that may be used within a facility setting. So again, safe injection practices are really critical even for the cholera response. Cleaning and disinfection of patient equipments, again, important. We talk about contact precautions in cholera, and really for general hygiene within the facility setting, it's critical that we ensure that we have cleaning and disinfection of equipments as well as environment. And again, linen management. We have soiled linen in the facility. We have soiled linen among cholera cases, so we need to adhere to that, and waste management as well as patient placement. So once we have our bare minimum, which is the standard precaution, now we move to the transmission-based precaution, which is on my extreme right. So these ones are based on the infection at hand. So this, now we are talking about cholera. So for cholera, we are really talking about contact precaution. And in this case, we need to isolate the cases. You would not want maybe an adult who coming in with cholera being mixed with a patient on dialysis or a cancer case or a HIV disease stage 4 patient, because these are patients who are likely to succumb to cholera. So we need to isolate them so that they don't propagate infection within the facility setting. And in this isolation area, we need to have posters and signages for contact precautions, which would include
hello,
hand
Dr.
hygiene.
Deborah.
Yes.
Can you go a bit slower for the interpreters? Thank you.
Oh, sorry for that. So for the contact, so we need to have posters that will help us to have the precautions at hand. Again, we need to have the appropriate PPEs. And since we're talking about contact precaution, then gloves are there. We need to have gowns. We need to have, aprons, which are fluid resistant to avoid contamination with the bodily fluids, such as feces and vomiters. Again, we need to have dedicated materials. And if this is not possible, then we need to have cleaning and disinfection of equipments between our patients. Other transmission-based precautions would be adhered to during patient transport and movement, so we limit that. And also we need to improve our communication for the patient and the visitors as well. So we move to hand hygiene promotion, and we are also talking about IPC practices, and these should be organized for all patients and caretakers. So in my extreme right, we are talking about the multimodal approach, which are the 5 approaches for IPC, strengthening IPC practices within the facility for patients, caretakers, and health workers. So the first one is build it, and then teach it, check it, sell it, and leave it. So in building it, what we are saying is that we need to have available like for hand hygiene measures, we need to have available hand hygiene stations. We also need to have appropriate PPEs for use and other IPC supplies. Again, for the flow of movement, we also need to have the infrastructures available to ensure the same. And in teaching it, what are we saying? We are saying that patients, caretakers within the facility need to be trained. We can have health education maybe in the morning hours before we start our routine activities in the facility. Again, for check it, we are saying we need to monitor the IPC practices. Are we using safe water? Are we monitoring the quantity and the quality of water? Are people practicing hand hygiene? Are we having clean latrines, etc.? Again, selling it, we need to have posters within the facility level. We can have hand hygiene posters next to every hand hygiene station, and we can have posters for cleaning and disinfection, for mixing chlorine, so that everyone is well informed. And in living it, we need to have IPC champions. We need to have sustainable IPC practices. And I think one of the things I need to say is yesterday we had a meeting, and one of the things we're deliberating is during COVID-19, people were washing their hands within the facility level in the community. So what has changed? And now living it is really what highlights that. We need to have sustainable, we need to have lifestyle or culture change to ensure that these IPC practices are sustainable even after an outbreak. So for hand hygiene, we have the 5 moments of hand hygiene. 2 are before and 3 are after. So before touching a patient, we need to wash our hands, and before a clean or aseptic procedure, there's need to wash hands. And after touching the patient's surrounding, as well as after touching body fluid exposure risk, after body fluid exposure risk, we need to wash our hands. Again, for cholera, it's critical that we wash our hands when entering and exiting a patient's area, and also after using latrine or handling a patient's or a child's feces, as well as after handling dead bodies, and before and after preparation or handling of food. So those are other important times, and it's critical that we have such posters for our colleagues to be informed. This is just to show us the hand hygiene technique and really highlighting the critical areas that are missed when we are washing our hands. So we need to have such posters in our hand hygiene stations to remind our health workers on how to wash their hands, and also the patients, and as well as visitors. Again, this is the hand rub technique. And again, really emphasizing on the multimodal approach of building it, teaching it, checking it, selling it, and living it. So how about the personal protective equipments? What we are saying is that all healthcare facilities, it is preferable that we wear we do not wear personal clothing while on duty. It's important that we have scrubs that are used. At times you go to a facility and the clothes that a health worker has come with are the very same ones that they go home with, and yet they have been contaminated with the various microorganisms. So we really recommend that we have scrubs, or that they have clothing that they can use in the community, and those that they use at facility level. Gloves must be worn whenever there's a direct contact with vomiters, stool, or any bodily fluids, and mucous membrane also contact or non-intact skin is anticipated. And gowns are also critical in terms of protecting the skin and preventing soiling of clothes. And if the gowns are permeable, then it is important to also add in a fluid-resistant, waterproof apron on top of the gown to protect yourselves from bodily fluids and splashing of infectious material. So personnel who are on who have direct patient care, conducting cleaning and disinfection, managing cholera waste, and handling high-strength chlorine solutions are really need to wear PPEs. And at times we notice that health workers, especially the medical staff, the nurses, are really wearing the appropriate PPEs, but we tend to neglect some colleagues, such as the support staff, who are conducting cleaning and disinfection, as well as the waste management and the mortician. So while you're conducting training, let us ensure that they have been trained on IPC practices and they are using the appropriate PPEs for their various procedures that they are conducting. We need to ensure availability of at least 1 month supply of disposable PPEs. That is really critical. And again, for the reusable PPEs, it is important that we also chlorinate with 0.2% chlorine solution for 10 minutes to get or to kill the microorganisms. So this is really what we're talking about. We need to have scrubs, short-sleeved tops and trousers, and then we have gumboots. And for the staff who are not exposed, like the administration and the kitchen colleagues, then they can wear rubber clogs. So staff must never leave the CTC in their home clothes. They should not stay in the CTC in their personal clothes. We should have clothes dedicated for the CTC, and then they leave the facility with home clothes. So for activities such as IV insertion, collection of stool sample, contact with mucous membrane, and also if a medical staff has skin lesions on the hand, we recommend that you use disposable examination gloves in latex or nitrile, and then isolation gowns and disposable aprons based on risk. Again, for collection of soil, laundry, and dishes on transport of the same, then reusable rubber gloves and reusable plastic aprons are recommended. And in preparation of chlorine solution, washing or disinfection of laundry and materials, as well as transport and elimination of wastewater, feces, etc., cleaning and preparation of corpses, then we use reusable gloves, plastic apron, and face shield. And for the elimination of waste, then you can see an overalls, work overall, reusable utility gloves, heat-resistant gloves, long apron, face shield, and disposable mask. So let us train our colleagues who are the hygienists who are really conducting cleaning and disinfection in the CTC, the waste management colleagues, etc., on the appropriate PPEs that they should use for the various procedures that they are conducting. Again, another challenge we observe is the chlorination of water, okay, or during cleaning and disinfection, among other activities. What is recommended is that 2% chlorine to be used for washing of bodies of the deceased person, as well as disinfection of waste containers used for feces and vomiters collection, and 0.2% disinfection at the patient area, toilets, etc., as well as disinfection of the cholera beds, PPEs, and patient sheets, etc. And 0.05% can be used for hand hygiene. What is recommended is soap and water first, but if not possible, then as a last resort, hand hygiene using 0.05% chlorine is recommended. So what is advised is you need to know what is the type of chlorine in your setting. Is it HTS, HTH, NADCC, is it sodium hypochlorite, yeah? And what is the percentage of active chlorine? From there, then you can calculate the percentage of chlorine that you will utilize for the various procedures. What is recommended is to have a standardized, a standardized type or active chlorine, so that when you're making your SOPs, you're all at par with the various health workers, and you can be able to monitor and control infection. So when conducting cleaning and disinfection, what we recommend is a 3-bucket system. And in this one, what we are saying is the first bucket is used for washing. So this one has soap. And the second bucket will be used for rinsing. And the third one is for sanitizing. And we are sanitizing using chlorine, as described earlier, the percentage of chlorine as 0.2% chlorine. So regarding water supply, we know that there are many activities in the healthcare facility. We'll need water for preparation of ORS, for cleaning and disinfection, for the visitors and patients, for sanitation and flushing the toilets, among others. So water is calculated based on that, and what is recommended is 60 liters per patient per day and 15 liters per accompanying person per day. And we need to have 3 days of safety stock and have appropriate reservoirs on the quantity of water. Again, a challenge we observe is the quality. We are not monitoring the quality of water. It's important to have improved water source, to review the turbidity as well as the free residual chlorine level of water being used in the CTC. So for sanitation, latrines, toilets, and shower facilities, they need to have a roof, they need to be gender segregated, and have lockable doors and easy to maintain tiles. And then they should be culture sensitive as well. So at a bare minimum, 1 latrine or toilet is recommended for every 20 people in the observation and recovery area, and 1 for every 50 patients in the inpatient, and 2 latrines in the neutral area and 2 in the visitors area. And all the biological fluids need to be emptied in the latrine and the toilets. Another gap we observe is the shower. where we some CTCs may not have. But what is recommended is that we need to have showers in a ratio of 1 for 50 people in an observation hospitalization area as well as a neutral area. And let us not forget hand hygiene facilities in each toilet within a 5-meter distance. Waste segregation, very critical. All waste that is generated from a CTC or CTU is an infectious waste. So it must be treated and disposed of on site in a dedicated area. And the waste must be collected separately in at least 3 different containers. We have the general waste, we have infectious, and sharps waste. And the waste must be marked and fenced. Yeah, at times you have rainy season, and this can lead to contamination and spilling of all the waste even into the community. So we need to ensure that this place is secure. And I think all those aspects will be discussed by our WASH colleagues. Again, laundry, all soiled materials, they should be separated and immersed in a 0.2% chlorine solution for 20 minutes. And this should then be washed in water with detergent and air dried. And we need to look at the laundry area where it should be a concrete slab. After cleaning and disinfection, then we need to have, we need to clean the area daily with 0.2% chlorine. Food hygiene, again, very critical during cholera outbreak. And what we recommend is that food should be provided on site and cooked and should be eaten when hot and heated to 70 degrees. And those who are preparing food need to observe strict hygiene rules. No leftover should be taken at home because this could be contaminated food and may propagate infection. And our kitchen staff should also be trained on food safety practices. Again, the utensils should be washed with detergent and disinfected with 0.2% chlorine. For corpses, this is one of the critical tasks for the CTC and CTU. We need to, once death has been certified, the corpse is moved to the morgue, and then there's the preparation of the deceased, which includes washing and disinfecting with 2% chlorine and plugging the orifices with a cloth that is soaked in 2% chlorine. Intestines should not be emptied for obvious reasons, contamination of the environment. And then the handlers, the mortician, should wear the appropriate PPEs, which should include gloves, mask, gown, gumboots, and so on. And body bags, if available, should be used for transport and should be placed, the body should be placed immediately in a bag after disinfection. If this is not available, then you can have a cloth or towel soaked in 2% chlorine and wrap around the body. So another thing that is not used routinely is the GTFCC CTC CTU assessment tool. We would like to recommend that you use the assessment tool as you conduct assessment for the IPC, case management capacity within the CTC and CTU. So this is a tool that was developed by the GTFCC task force. It has 14 indicators, and the frequency of follow-up and formative supervision is defined according to results. So it is categorized based on priority, the top priority that needs to be intervened within the 24 or 48 hours. I think Dr. Kamara had talked about IV fluids and dehydration. So if you find that maybe severe dehydration, a colleague is only being given ORS, that is a prompt thing that you can work on, educate them on IV rehydration, IV fluid rehydration, etc. And then there are those which are high priority within a week. Maybe we don't have an IPC focal point or a staff at site. It would take some time before we have one recruited. So that would take a week. And then there are those who are at priority as soon as possible. And then those are which are good practices. Say, for instance, an area for cleaning and disinfection with the appropriate measures that would take some time to get the resources. So the variables are listed below. We have IPC variables such as hand hygiene station, the facility layout, screening and triage, hospitalization area, how are the patients being treated, are they on the right medications, the kitchen and the meals, as we talked about, food handling, the water quality and quantity, the latrines and showers in good proportion, is waste being managed well, what is the dead body management in that setting, are the protocols and procedures, well posted for all the health workers to see, such as the one that Dr. Kamara had shared, or the one I shared for hand hygiene, and also for cleaning and disinfection, data management, staffing, IEC, among others. So we would really encourage that you use the GTFCC tool. And upon having the variables, then as we said, then they are prioritized. They're those that are top priority, that you can have the interventions within 24 others, and then there are those ones that would take time. So following the trainings that you can have, we encourage you to utilize this tool to identify gaps and improve capacity within your facilities. So that's it from me. Thank you very much. Over to you, Dr. Olaolu.
Thank you so very much, Dr. Deborah, for that eloquent presentation. There were quite a lot of information that has been passed across. I know colleagues would have some questions, so this is a time to raise your hands or to use the question, type your questions in the question and answer box. But for the meantime, before we look at those other ones, there's a question on the chat here, which is how should the cleaning and disinfection of scrubs or cholera treatment center dedicated clothing be done? By who and how often? So if you could just ask this question before we see whether there are other hands that will be raised in the hands raised electronically. Dr. Deborah?
Yes, thank you very much for that question. So according to the recommendations by GTFCC, we can wash the scrubs with detergent and water. So unless maybe what should have been highlighted, if there's spillage or contamination with soiled bodily fluids, then it would be recommended that we also add the chlorine, 0.2%. We have a contact time of 10 minutes, then we wash with soap and water.
Okay, thank you. So we have some hands raised up. I'll start with the. Okay, thank you, Dr. Deborah. So we have Joseph Asana. Your hand is raised. You can ask your question. Kindly unmute. Joseph, can you unmute? Yeah, Joseph, yes, you can ask. Unmute your device. Okay, seems we're having some challenge. Let's go to Balarabe Salisu. Please, Balarabe, your device. Okay, go ahead, Balarabe.
Okay, hello, good morning, Ma. Thank you very much for this wonderful presentation. My question is that about the body disease preparation. So the preparation of the body deceased is what I have a question about. Thank you very much.
Please, what specific aspects do you want Dr. Deborah to address?
You said, sir?
What specific aspect do you want her to address?
Okay, the specific aspect is the amount of the chlorine used in body deceased preparations.
Okay, all right, thank you. Let's go to Mamadi Dokore. Kindly unmute your device.
Ok, bonjour à tous et à toutes. Et moi, je suis Doukouré Mamadi au ministère de la Santé de la République de Guinée. Et donc, j'ai pris l'intervention en marche, mais les présentations que j'ai vues déjà sont très, très importantes. Donc, du coup, je dirais que toutes les mesures qui ont été signalées par rapport à la prise en charge du choléra sont des mesures vraiment capitales. Connaissant que Ebola déjà a été des grands exemples dans notre pays. Voilà, donc du coup, aujourd'hui, l'hygiène des mains, l'hygiène alimentaire, l'hygiène environnementale sont devenus des actions coutumières. C'est devenu une habitude dans le comportement des uns et des autres. Mais l'une des choses importantes qui a été dite dans cette communication, c'est surtout le fait qu'on a mis l'accent sur la communication. Toutes les mesures sont bonnes, isolation, tout ce qui est hygiène corporelle, mais la communication reste la clé la plus importante pour prévenir toutes ces épidémies et pour pouvoir vraiment améliorer l'état de santé des populations. Et aussi, n'oublions pas de faire l'approche socio-anthropologique dans nos communautés, parler de la maladie, parler des comportements. Donc, c'est ce commentaire que je voudrais faire, sinon je n'ai pas de questions. Merci à toutes les présentatrices et tous les présentateurs.
Thank you, Mamadi. Let's take the probably last but one. We have Fatima Saleh. Fatima Saleh, kindly unmute your device.
Okay, so thank you, WHO team. I really appreciate and thanks for sharing the link with some of us. Fatima Saleh is my name. I lead the cholera case management pillar lead for Nigeria. So I have this question to ask, considering the IPC considerations for the disease. So I'm wondering if the WHO have some advice or guidance based on some peculiarities. Because I remember being sensitive to people's culture and religion is one of such things that is being factored in. So for some of those that, let me give an example specifically for Muslims, they have these rituals, ritual bath that it's been conducted on the deceased. So I don't know if you guys have such a kind of peculiar guideline or guidance or advice for such scenarios, knowing how sensitive it is. Thank you again. Over.
Okay, thank you, Dr. Fatima, for that question. Okay, let me ask Professor Bola to respond to that. Then we'll come back to Dr. Deborah. Prof?
Thank you, Dr. Fatima. You will realize that WHO is a worldwide organization and an international organization. So many times the guidelines are generic, but there is room for each country to adapt the guidelines in view of their peculiar context. But when you come to preparation of the dead body, we know that these were issues in like the Ebola response and all that. public health, safety, and law is important. There are cases in which there have been things like dry washing, and these have been done in collaboration with the religious leaders on what is the best thing to do, taking note of the person's religion and culture, but also what is safe and would not allow for transition. So these are some of the things that happened. And I know this has happened in Ebola outbreak response, even during the COVID response. But understanding the transmission of the disease, you will understand that cleaning out the intestines, which is the place that harbors the Vibrio cholerae, in preparation for burial, is actually releasing Vibrio cholerae into the environment and increasing the risk of transmission to the people who are preparing the dead body and also to other people within the environment. Over.
So thank you so much, Prof. I saw a hand raised earlier. It's Alberti. The hand is now down. Do you still want to come in, Kate?
No, it's fine. Thank you. I think I was just, I'm having trouble answering the Q&A, so apologies for that, but my colleague Nadia is helping with that. Thank you.
Okay, thank you. So Deborah, over to you. So the questions about how cleaning and disinfection of scrubs and facilities dedicated material clothing should be done by who and whom, and all the other questions that colleagues have asked, also trying to look at how we can communicate this disease to the community. Over to you, Dr. Deborah.
Yes, Dr. Olaolu, I can see our IPC AFRO team lead's hand is up, so I will give him the floor to answer and comment. Thank you.
Okay, thank you. My comment is around to response in the community. I think two colleagues asked almost the same question. I will speak in French. Je pense que c'est très important lorsqu'on répond contre l'épidémie de choléra de vraiment travailler de manière très rapprochée avec la communauté et de s'assurer qu'on comprenne bien les habitudes de vie de la communauté, qu'on comprenne bien leur mode de vie, leur religion, les rituels et tout ça. Parce que la source de contamination peut être liée à leur mode de vie. Comme vous le savez bien, il y a des modes de vie qui favorisent la propagation de cette épidémie, notamment la défécation à ciel ouvert, notamment un traitement inapproprié de la nourriture. Donc, au préalable, il faut pas copier-coller tel quel ce qui se trouve dans la littérature, mais il faut d'abord comprendre comment fonctionne la communauté dans laquelle on veut répondre et adapter les recommandations ou les mettre dans une forme de sorte que ces recommandations-là soient accessibles à cette communauté-là. Donc, je soutiens les propositions de Dr. Fatima qui veut qu'il faut vraiment comprendre ce qui se passe dans la communauté et agir de manière à ce qu'on puisse avoir des résultats qui est le changement de comportement. Merci à vous.
Thank you so much, Dr. Landry, for that. Sorry, apologies, I didn't see your hand. Thanks for that contribution. I can also see Zach's hand up. You can kindly speak.
Thank you. Can you hear me?
Yes, we can.
Okay. I just would like to respond. So not in the Q&A, but on the chat. Somebody mentioned that washing the dead bodies with 2% chlorine disformed the dead bodies. And due to that, the practitioner decided to use 0.5 instead of 2. It is true that using the 2% concentration is a strong chlorine concentration. It's very you can feel that it's something you need to be careful about, and it's true it might have some impact on the dead bodies. But then you need to find the balance, and we come back to what was discussed before, the discussion with families or communities. What is the balance for the risk here? Do you prefer to have a clean body, or put maybe the family at risk to get cholera because a dead body is highly contaminated? So that's what you need to think about. If you decide to reduce from 2% to 0.5, then you might put at risk the people who clean the body, and maybe the family who will take care of the dead body, maybe kiss him, because that's very common in a lot of customs. So that's why usually we use the 2% chlorine. That's over for me.
Thank you so much, Sax, for that input. So let me hand over back to Dr. Deborah for the responses, or to close this session up. Over to you, Deborah.
Yes, thank you so much, Dr. Olaolu. And thank you, colleagues, for the wonderful questions and the wonderful comments. I really like the social anthropologic measures. And I believe Dr. Landry and Dr. Sachs have answered the questions appropriately regarding the dead body management. So the GTFCC task force has talked about, it incorporates the member states as well as organizations all over, and it follows evidence-based medicine. So currently 2% is the recommended and not 0.5%. So we would recommend that we adhere to that until further evidence is available. So thank you. I'll continue answering any questions in the Q&A box. Thank you.
So thank you so much, Dr. Deborah, for the presentation, and other colleagues for the questions, and panelists for the answers. We have resources from the Global Task Force for Cholera Control. It's been put on the chat, so it'd be nice if our colleagues go to that site, download the materials, and this is what will really help in our response to cholera. So we'll go to the next presentation, which is on implementing water, sanitation, and hygiene during a cholera outbreak. So this will be taken by our colleague Lauren Sachs from the WHO HQ.
Thanks a lot. I'm just going to wait that the presentation is shown. Thank you. So the idea here is to get an overview of the WASH response in different settings during the cholera outbreak, and taking in consideration that here in the audience we have mainly health persons, some WASH obviously, but not too many specialists. So the idea is really to get an overview and not to go too much in details. For the details, you have the good overview with the IPC presentation just before, and also I'm going to direct you to some resources at the end of this presentation. So in case after we're going to have a Q&A, obviously, but you can see two email addresses, which is my own and the one from Guy Bayo, who is the AFRO WASH officer, regional officer. So that's people you can reach if you have questions in the future. Next slide, please. So this is just to give you an overview of the presentation. I'm going to start with the relation between WASH and cholera, talking a little bit about the transmission routes. Then I will speak about the relation between WASH and the other pillars. Then I'm going to go more in details about the actions, WASH actions that can be implemented during the outbreak. I'm going to go a bit deeper into the healthcare facilities, into the communities, and then speak a little bit about specific cases. At the end, I'm going to speak also about some WASH actions that can be implemented at the end of an outbreak after the response. And finally, speak about the existing resources online and some additional slides that I'm not going to explain, but that are going to be available once this document will be shared with the audience. Next slide, please. So as a start, we always hear that WASH is a very, very critical to cholera. Why is it so? It's very basic. It's just mentioned in this first sentence. Cholera is transmitted after ingesting food or water contaminated by the bacteria Vibrio cholerae. So it's water contaminated mainly. So that here you have the answer why WASH is so important. And this transmission, this cholera transmission, is closely related with inadequate access to clean water or sanitation facilities and also poor hygiene practices. So you will find those risk areas in peri-urban slums when you have a lot of people living together, in remote areas, while sometimes it's a bit difficult to have good access to water. And also when you have IDPs or refugees camps, it's also areas when you might have some inadequate water, sanitation, and hygiene. Also, you may have at first some good water and sanitation system, but they might be disturbed for different reasons, mainly related to humanitarian crisis. It can be natural hazards, conflict, displacements of population. All those might have an impact on the WASH systems and then might have an impact on the cholera and raise the cholera outbreak. As a conclusion for this slide, all the WASH interventions that you can do might prevent waterborne illnesses. They can also contribute to achieving goals with poverty, malnutrition, and education. So what you need to understand by that is the positive impact on WASH actions goes beyond the cholera reduction. So it means it's important for the decision makers not to keep your eyes only focused on cholera when you have WASH actions, but the positive action will have results far beyond on cholera. Next slide, please. So this slide has been shown on different images, but it has been shown also just previously on the IPC presentation, but also on the previous webinar last week about the transmission routes of cholera. And it's highly WASH related. That's why I would like to take again a look at it. So basically, when you see this diagram on the right side, you will see that if you have not good sanitation infrastructures, if you don't have a proper safe water, and if you don't have good hygiene practices, you will see that cholera will be able to pass from a host, infected host, to a new host. But if you improve all those different components of the WASH, sanitation, safe water, and good hygiene practices, you may have a lot of chances to reduce this transmission. So this is really the key the key message I would like to transmit here. Next slide, please. So talking about pillars, this picture here is taken from the GTFCC main document, which is the roadmap for 2030. You have different pillars. You have 5 pillars plus 1, which is the leadership and coordination. So except from WASH, you have surveillance and reporting, you have the vaccination, OCV, healthcare system strengthening, and the community engagement, LCCE. And all of them have in different quantities, I would say, a WASH component. If we take the example of RCC that I'm going to talk a bit more in detail afterwards, you will have some intervention in the community with, for example, chlorine distribution, but also messages that you're going to spread about the good hygiene practices. If we take about the healthcare system strengthening, we had a very good examples with the previous presentations. Before, I mean, you could see there is a lot of mentioning about the WASH in sanitation, water, and hygiene. If we speak, for example, about surveillance and reporting, when we speak about surveillance, about the epidemiological data, that can give us good information about where to have WASH actions. If a lot of cases are coming from a specific area, then we can go there and target WASH actions. And finally, when we speak about vaccination or CV, usually what we can do is to take the momentum of the vaccination campaign to assess the WASH infrastructures in a community where you have the cases, and then you can implement actions either directly or at middle term, long term. Last but not least, the leadership and coordination is a key topic because as it is common that the health ministry and the MOH are usually the one leading the response, the WASH ministries are related, must be involved in the response to have a good coordination. Next slide, please. So for the global response, first, before the response, there is a need to investigate what's happening, where it is happening. The idea here to do some survey phase investigation is to identify potential source of contaminations, whether it's a water source, it's a custom of open defecation, it may be a streams that is contaminated. As I previously spoke, epidemiological data are key also to identify the source of contamination. This can be found with some survey questionnaires that are made in healthcare facilities. Those investigations, the WASH investigation, can be done in the community, but also in the healthcare facilities. So this is key to really target the response, because if you don't do that, you will lose your resources. It's going to be diluted, and you're not going to have a good impact on your response. So a global response can be in different branches. Here is a list of the main actions you will be able to implement. So first is to improve the WASH standards in the healthcare facilities. I'm going to speak a little bit more about that in the next slides. Also is to implement or improve the water quality monitoring. And then it's also to improve the water quantities to avoid concentration of the population, because more population concentration at a water source, the more the risk. You need also to adopt protective hygiene measures, such as hand washing, also storage of food and water. Also, you need to construct emergency latrines and manage the wastewater maintenance with dislodging the latrines. Then you have to implement the CATI method. I'm going to speak a little bit about that. It's made of decontamination of households, provision of soap or other products to clean the hands, and it's also other activities. Then at the end, it's also cholera kits distribution, mainly in the community. Again, those kits can be made of hygiene kits, chlorine products, and buckets to collect water. That's really global. Now we're going to go a bit more in details. Next slide, please. So this is a checklist that is taken from one of the GTSCC guideline, the field response guideline. So this is summarizing just what I spoke a bit before with different words. The basically, it gives you an idea of what you need to check or to do when you want to do an answer on the WASH. The box in red is the WASH, but the other boxes is related to the different pillars, just for your information. Also, on the top right, you will have the name of partners and responsibilities, because obviously, depending on what is going to be done, some organizations can be the state, can be private sector, can be NGOs will be able to answer. For example, if you want to work on the food safety in markets, streets, and food vendors, maybe the FAO is the best actor to implement activities. All relations to provision of safe water can be related to UNICEF, etc., etc. Next slide, please. So now I'm going to go a bit deeper into the WASH actions in healthcare facilities. It has been discussed also in the previous presentation, but basically I'm going to take a step back to make you understand why is it so important to have good WASH standards in healthcare facilities. If you don't have that, or if you have them, you will prevent the cholera transmission within the structure and within the surrounding areas. So basically, a healthcare facilities, you have cholera patients, so they are the ones who might transmit the disease. But if you implement the good standards in the water, in sanitation, in hygiene, you will reduce or even better cancel all those risks of transmission. So what are the different actions you may take? It was given a lot in details in the previous presentation. That's why I'm not going to go too much in details, but you can see here some of them. So it's hand washing points for everybody, for all. So we are talking about staff, caregiver, patients, and it's each zone of a healthcare facility. We talk also about sanitation facilities like latrines dedicated for everybody. So you will have some for the staff, some for the patient, some for the caregiver to avoid the transmission. Once again, the maintenance is a key. You need to disinfect them regularly. And then water supply, it has been mentioned before, but it's something very important. You need to have water in sufficient quantities. These numbers, you need to remind it, 60 liters per person per day. I'm going to talk a little bit more in details in the next slide. And you need to have proper chlorination batches for disinfection, for cleaning, for the body, and you need to monitor this water. So if you remember, we spoke about 0.05 percentage chlorination, 0.2 or 2%, depending on what you need to do. Another important thing to mention is the concept of nothing goes out when you work in a healthcare facility, meaning all that is going in with the patients might be contaminated at some point, so it needs to remain in the structure. So the waste is incinerated. We can speak about the remaining food for the patient or for the staff. We can speak about the clothes. We can speak about everything. The only thing I would say that goes out is obviously dead bodies after a good process, and these patients are being cured, and that's it. Also, the water cannot be exposed wherever the water that is being inside the structure. It needs to be infiltrated with appropriate drainage pits. I'm going to talk a little bit about that just below. You need to avoid this water to be in contact with the groundwater and the surface water, because once again, if you expose the water into a river that is nearby, you might, and this river is used by the population, then you're going to create a risk of transmission. Last point is what we call decommissioning is at the end of an outbreak, when you want to close the structure, or if it's an existing healthcare facility, you need to disinfect it completely. You need to use specific things to do it properly. So the method will differ if it's an existing structure or a temporary structure. I'm not going to talk about it in details once again now, because we don't have enough time. Next slide, please. So I want to go just a little bit more in details about the water quantities. When we speak about those 60 liters per day, and also we speak about 50 liters for caregivers, we need to understand why is it so much? Because the water is used for drinking, obviously, but it's used for prepare the oral rehydration solution, to wash the hands, to the shower, to clean and disinfect surfaces and equipments. And this is done several times a day to clean the food, to do the laundry, prepare the dead bodies. So just to give you an idea of how much we are talking about, if we have a cholera treatment center of 60 beds, and you always need to have a 2 days backup of water supply. So you will have a total of nearly 11 cubic meters of water in stock at all time. Although you cannot take the risk to have no water or very little water when you are responding an outbreak in a treatment center, cholera treatment center. On the right side, once again, it has been mentioned in previous presentation, and this is taken from the GTFCC field cholera guideline, but you see the different percentage of solution that can be done with different chlorine products, and what is the use of it, and on the bottom, what is the precaution. So that's very helpful. You find also this information on the application GTFCC app that I mentioned briefly at the end of this presentation. Next slide, please. So now when we speak about the response in the community, this is a really key topic, because that's where we have sometimes the more difficulties for different reasons. The community might not know what's happening, might be a bit have fear about the disease, might have fear about the authorities, so as they have some beliefs. So that's also why it's so important to respond in the community. Once again, I mentioned that previously, but before any intervention, you need to investigate. You need to understand what's happening in the community, how they behave. Otherwise, your intervention will not be well targeted and it can be counterproductive. So this is an overview of what can be done in the community. If we speak about the water, you can chlorinate the point of use. You need to understand where are the point of use. It can be maybe at a tap that is used by just a compound, a yard, or it can be at household level, or it can be more global. It can be next to a market, etc. So you need to understand that. You need to monitor the water quality at different level, but at household level is one. And I'm going to talk a little bit about that just after you. You need to share the key messages about the safe water collection and the handling and the storage. Why? Because you have a good water quality when you collect the water at the pipeline, but if you don't store it well, then you might contaminate it. So this is some message that really needs to be shared in the community. Also, what you can do, you can distribute chlorine products. This is done, there is different ways to do it with aqua taps, for example. When we speak about sanitations, there is some possibilities to improve the existing structures. You need also to manage the wastewater because otherwise it can contaminate the water supply. And you need also to manage the solid waste. The solid waste don't have a direct impact on contamination, but it gives you an idea of how is the sanitation in the community. And another point that is very key is about open defecation. Open defecation is a high risk of cholera transmission. So this is once again something that can be reduced by construction of latrines, but that's not an easy task because basically you need to do to change the behavior of a community. Hygiene, it has been mentioned again several times, but you need to explain what is the importance of hygiene practices. You need to change the behavior potentially of the people. And if some burial are made in the community, which is very common, you need to explain, you need to speak with the people, and sometimes you may dedicate some teams who can manage the burial, supervise the burial in the community level. On the right side, so once again, you need to have the key messages spread it to understand, to make the population understand, because if you don't do that, the population will not accept the activities you want to implement. You need to adapt also the messages depending of the reality. So it can be the reality of different communities, religious communities, but also depending of what is available. We always speak about wash your hands with water and soap. Maybe soap is not available in the community, so you need to find a way to have some alternatives. Maybe ashes, maybe lime is not the best, but it's better than nothing. Once again, also the message can be different if we speak about females, males, or children. So this is very key. Next slide, please. This slide is a bit more technical, but it's very key. It speaks about the water quality monitoring during the whole distribution chain. So if we see what we call the source of water, this is where we collect the water. It can be a river, it can be a borehole, it can be a spring. So most of the time, if not every time, the water is not treated. So you need to treat with chlorine at that time. So what we call treatment chlorination. Then you need to ensure that your chlorination was made well. So you need to test the water. That's why there is this small symbol, this small tool that the WASH people might know. It allows you to check what is the free residual chlorine in the water. That's confirmation that there is still chlorine in the water. So when you do that at the water source, you can ensure a 2 milligrams per liter of free residual chlorine. It's okay. But then when you go further on the distribution, this number needs to be a bit reduced. Otherwise, the smell of the water will be too strong and people won't drink it. So you have a different way of distribution. It can be through a pipe network. It can be through water tracking if it maybe goes to a camp, or it can be through a bladder also, depending on the situation. Also there, you need to check the water quality, but not regularly because it has been checked before in the treatment area, but you can do several times a week. And then the last one on the right, you will have different households. The HH is for households. And you need to go there. You have teams dedicated to that to check how it is in the house. So basically, the person will go with this tool and randomly and check if there is still a free residual chlorine. If not, this is the key message also. If there is no water residual, free residual chlorine, it means there is something to do directly. It means you need to go back to the distribution or to the treatment to adapt your chlorination. So that's what is also key. When you don't see the free residual chlorine, you need to react. You need to chlorinate the water appropriately. And this all monitoring is very important to ensure that your water quality is okay. Next slide, please. Now I'm going to just take briefly about some specific other settings that you might have to work on where you have a high risk of cholera transmission. First, it's in prisons. This is very common. Why? It's because in prisons, it's quite often overcrowded areas, and the wash structures system are not always very good quality for different prisons. So this, you need to quickly implement the following actions. You need to disinfect the prisons. The prison, it can be time consuming, but it's key. You need to have some isolation units for the patients that might have symptoms. You need to improve the water supplies, even if it's temporarily, to reduce the risk. But what is very important is the last sentence. You need to balance the response in relation with the local population living around the prison. Why do I say that? If your response to the prison is very important and the population nearby doesn't receive anything, then they're going to fear that it's unfair that the prison is giving a lot of attention while the nearby community doesn't receive anything. So that's very important to take in consideration. Second information, second other setting is the mass gathering. So it can be the burials in the community, it's the market, it's the schools. Also, you need to go there to implement different activities. So it can be hand washing points, it can be message spreading. You can check what is the quality of the latrines here. If it's not good, you can rehabilitate them or at least implement maintenance. And you can also obviously improve the water supply in those areas, especially in markets and schools. Then the last area, which is not really a setting, but that's very important, is the cross-border between not only countries, but also it can be provinces, because that's how it works. I mean, a lot of countries in Africa have faced that recently. You had an outbreak in a country and then that spreads to another country. So you need to implement wash activities at the cross-border, especially when you have the main roads of travel between two countries. So key messages in this area: hand washing points, and improve the water supplies and the sanitation infrastructures. It's a lot of work, but that's very key if you want to cut the transmission at the beginning of the outbreak. Next slide, please. So as I said previously, we spoke about I spoke about the response during the wash activities during the response, but also some activities that you can implement at the end of an outbreak that can be very, very key to reduce the risk of the new outbreak, or at least to be prepared to a new outbreak. Staff training and pre-identified staff is very key. That's not only for WASH, but if people know what to do before, that's going to save some times when you need to implement the response. WASH partners pre-identified is very important. In a country, you will have several NGOs, several private sector people that are existing, so you need to know who they are and where they are, because when you have the response, okay, you can contact them directly, and you know to know who will have the responsibilities to do what. Some might be specialized in water supply, others in sanitation, others in spreading key messages for the community related to hygiene. Then you have also what you can do is WASH assessment to the PAMIs. The PAMIs is those areas where you have a hotspot, a lot of potential cholera cases. That's where you're going to target your WASH activities to the middle to long term. You can also predispositionate some material, can be chlorine, because chlorine sometimes is an issue in some areas. You have a shortage of this product. And you can implement hygiene education programs. That's very key. You have a lot of other things to do, obviously, but that's something you can implement quickly after a response. At the end, some challenges you will have to do that, which are, I would say, not only related to WASH, but that are very important, is the cost of this investments. That can be a challenge, but that's why it's really important to target those investments into those families, those hotspots. Also, the maintenance, the infrastructure is very difficult. So this is something usually that needs to be implemented by the state in partnership with maybe private sectors, because this is a middle to long term. If the maintenance is insured, then you have it's a good start to reduce this the transmission, to reduce the transmission. Also, it's related to that. It's to create a bridge between the humanitarian response. This is usually the one you have during an outbreak, and the development world. We are talking about the stakeholders, the NGOs, the private sectors, the states. And obviously, little mention is the unexpected event, that it's a bit challenges when you have a natural hazard, when you have conflict. It's difficult, it's related to preparedness, but that's always a challenge. You can never really prepare at 100%. Next slide, please. So this is a brief list of resources available in English and in French on the GTFCC website, mainly. Most of the information that has been presented here and the images come from those documents. So you have some about the IPCs, WASH and IPCs in CTCs, CTUs. I mentioned the chapters. You have the cholera outbreak field manual with the section 6 specific also on communities, also on section 8. You have a technical note which is called environmental surveillance related mainly with, not mainly, but with water quality monitoring. This one will be reviewed at the end of this year and early 24, but you have the French and the English version available for the moment. And also what has been mentioned several times, this is the free cholera app available for Android and iOS. That's very useful for the response. You have some good information for the WASH when you want to prepare your chlorination batches, for example. And at the end, you have the WHO cholera fact sheet, which gives you a very good overview of what is cholera, what can be done in the different pillars. The existing fact sheet is good, but you will have a new version updated in the coming months. Next slide, please. So just 3 slides here. I'm not going to talk about them, but you can just go through them very quickly so the audience know that they are existing. Next slide. So this is a treatment center, an example. That's an MSF image, which I think is very good, shows everything. Next slide. This is just an example of where the CATI response can be implemented and compared to other response in the community. So CATI mainly at the beginning or at the end of an outbreak, but other response. Next slide. This is also the standards in healthcare facilities in different WASH components. That's all for me. Over.
Yeah, thank you so much, Lauren, for that eloquent presentation. And we can see that there are quite a lot of resources for colleagues to really look at there. You have the presentation at the end. I think for most of the questions that were raised, they have been answered in the question and answer chat box section. So really want to thank Lauren for the presentation and also participants. In the interest of time, I'll just hand over to Professor Bola to round up this session, which has been a very interactive one. I thank you. Over to you, Prof.
Thank you very much, and thanks to everyone. I think there's just one question, and Sachs, if you can quickly take that before we round up. It says, may I suggest that some light is thrown on the relationship between household water treatment and safe storage, and what does it have to do with cholera prevention?
All right. So let me read the question again. I have it on my front of me. Give me 1 second, please. Okay, so just to be sure, so we are talking about two different things. Huh? The treatment at home is basically when the water is not yet treated, and people will treat it at home through, it can be boiling, it can be using of those aqua tabs, different possibilities, that's one. And then the storage is, once it has been treated, is how do you keep it safe for the time you are not using. So because usually then you keep it in different containers, can be a bucket, it can be a reservoir, whatever, and that's how you keep it there, and for how long time you keep it there. So that's the two very different things, and both are very important, because if obviously if you don't treat the water, maybe it's not contaminated, but so if you treat it and you don't store it well, maybe you think that because you treated it well, you are not at risk. But then afterwards, maybe somebody comes in your house, or maybe even yourself, you have cholera, you put your hands in it, and then you contaminated the water, and then you might contaminate the entire house. So that's those two comments. Treatment is one to make the water safe to drinking, and the second is the storage, to ensure that when it's treated, it's safe for the time, until the time you are completely used it.
Okay, thank you, Sax. Thanks for the response to that. So we've come to the end of this webinar, and I'm sure you'll agree with me that it's been a great time. We've looked at case management, we've looked at infection prevention and control, and we've also looked at the importance and the relationship with water, sanitation, and hygiene, and how all these fit into effective cholera response and control. There was a question regarding antibiotic advances in antibiotics and all that, and which ones are the current ones. That is not within our scope for this, but just like we mentioned, there are still going to be quite a number of cholera-related trainings going on till November this year. But these first three are particularly related to responding to cholera outbreaks within the region. Sax, I'm seeing your hand up. You want to say something?
Yeah, it's just because there is a question. Do you have time for the last questions, which are more related to the conditions to add additional units? Is it okay to respond to that one?
Okay, please.
Okay, I will do that in French. I think it was asked in French. Quelles sont les conditions pour mettre en place des unités supplémentaires de traitement? Donc la question, en fait, elle va dépendre de comment est l'évolution d'une épidémie, parce que l'épidémie peut rester dans un endroit où elle peut se déplacer. Donc, elle va forcément être fonction de la disponibilité des lits. Si à un moment, d'une part, dans un CTC, c'est plein, on va devoir en construire un autre. Et la deuxième chose, c'est d'être le plus proche des patients. Donc, si on voit que tout d'un coup, des gens mettent 2 heures pour arriver à un CTC, peut-être qu'il y a un foyer qui est dans un autre endroit, et on va aller au plus proche là-bas pour voir où est-ce qu'on peut construire des nouvelles unités. Et après, la taille va dépendre du nombre de cas. Donc, pour rappel, un CTC et un CTU, la différence est assez faible. On parle du nombre de lits. Normalement, un CTU, ça peut être 10, 20, 30 lits. Et après, on va plus parler d'un CTC. Donc, c'est ça qui va définir un petit peu les conditions pour mettre des unités supplémentaires. Et ça, bien évidemment, ça demande aussi la disponibilité de ressources humaines, bien évidemment. Et parfois, c'est la difficulté aussi dans certains pays, c'est qu'ils n'ont malheureusement pas les ressources, donc ça complique un petit peu les choses. J'espère que j'ai pu répondre à cette question. And Kate, maybe you want to add something.
Oui, merci. Je vais répondre aussi, juste ajouter qu'une des premières conditions, c'est qu'il y a la sécurité des patients dans les structures et assurer Donc, il y a toutes les questions d'accès avec lesquelles je suis tout à fait d'accord, mais il y a aussi la question de dès que les patients ne peuvent plus être isolés correctement dans une structure existante, il faut construire une autre structure. Donc, ça peut que une patient, il y a la place, il y a une facilité à isoler un patient dans une structure, mais dès qu'on ne peut plus isoler et que les soins pour les autres patients est affecté, là aussi, c'est un autre critère pour ouvrir une structure spécifique pour le choléra et pas traiter des patients dans une autre structure. Je vais juste dire, je vais le dire en anglais et en français. Il y avait beaucoup de questions par rapport aux antibiotiques. On a mis un lien dans le chat et à nouveau, j'avais mis le gtfcc.org/ressources. C'est le site web du GTFCC. Il y a un document spécifiquement sur le traitement, sur l'utilisation des antibiotiques en anglais et en français. Et je vous recommande d'aller le chercher et le lire. Il y a beaucoup plus de détails par rapport à l'utilisation de doxycycline pour tout âge, les groupes à risque, etc. Sorry, I'm just going to repeat something in English and in French. There had been a lot of questions about antibiotics, and my colleague, apologies, I had issues accessing the Q&A, but my colleague Nadia posted it. We put a link to a specific note, technical note from the GTFCC on the use of antibiotics, and this will provide more background information on antibiotics, on why we can use doxycycline in some groups which are unexpected, and who specifically is targeted. So that's on gtfcc.org/resources, and it's also posted in the chat. Thank you very much. I'll end there in the interest of time. Thank you very much.
Okay, thank you, Kate, and thanks everyone. And Nadia says on the resistance and novel antibiotics, that will also be handled during the further sessions. But you can also have a look at the GTFCC resources to know what it says about that. So we're already right on time. Our session ends at 11:30. I want to thank all the participants for being so vibrant and participating actively in the webinar today. Thanks to all our panelists and our presenters for giving us an insight into the things to do in response to cholera outbreak management within our countries and across our region. Thanks to the IT team and our interpreters. And next week, we're going to have the final session of oral cholera vaccines, especially the reactive type in the context of ongoing outbreaks. And then we're going to have a look at community engagement, risk communication, and also on supplies, logistics, ordering, and what to be expected. So thank you all very much for being a part of this training, and we are happy to have had this time with you. Thank you and enjoy the rest of your day. Over.